Hello, everybody. Welcome to another event in our IIH Practitioner Series. We welcome you all. We welcome you, especially if you're comfortable, to turn on your video and participate, ask questions in the chat. Tell us in the chat who you are, where you are calling in from, what part of the world. We've got people from a lot of different countries, which is very exciting to us. And especially if, for example, if your Zoom name just says, iPad or iPhone, or please maybe change your name if you're comfortable, so we know your name and we can all talk together, especially later on in the question and answer period. So thank you all for coming. I just want to introduce Dr. Pierre Goban. He is the CEO of Serenity Medical, and he is going to be moderating and introducing our speaker. Thank you very much.
Thank you all, and thank you for attending, and thank you, Dr. Starke, for joining us. So Dr. Starke is a professor of neurosurgery and radiology at Miami School of Medicine. He is also the co-director of endovascular surgery. He is also a researcher, and he has a deep interest in IIH and the treatment of severe IIH. Dr. Starke?
Wonderful. Is my screen still shared, or do I need to?
No, now you would share yours.
Right. Hopefully that's working. You see one slide or two slides?
One.
Perfect. All right. Well, thank you so much for having me today. And we'll talk about intracranial hypertension or pseudotumor and various treatment options. I think I always required to start with my funding disclosures. I don't have any relevant to IIH or to the River Stent. Most of my research funding is from the NIH and from the Department of Health, but I work with pretty much all the large neurovascular companies as well. I always think it's interesting, like, where people come from. People that are on this session. My background, I trained in neurosurgery and interventional neuroradiology. And, I think a lot of that training was fairly painful, but, it was also great, and this is really, how we learn and we go through the process. So I'm always fascinated to find out how everybody got here. But, I started out at Albert Einstein in Columbia, New York City. I did my neurosurgery residency at University of Virginia. Somewhere along the way, I had a kid. And then I did 3 fellowships, one in Thomas Jefferson, went back and did another year at University of Virginia, and then a year in Auckland, New Zealand. And I think this year in New Zealand was really a pivotal year for me, although it's seems like a long time ago now, in part because they have such a easier approval process than we do. So, even more than 10 years ago, we have many devices that were finally just getting here to the United States. So, this is my son looking around maybe for a patch of sand. And, I ended up at the University of Miami, but in part because of the research infrastructure. So I do about 700 cases a year, but I also have a basic science research team and a clinical research team. And really this infrastructure, having biplane angiography, MRI, CT, ultrasound, just for research, was the main reason I took the job here. So I always think about, as part of your training, you want to have one aspect of all the tools, and that's because if you just have a hammer, everything looks like a nail, even if it's a rabbit. And sometimes when you put, the hammer together with a rabbit, you end up with a lot of nails in your head. And so this was actually a patient that was hearing a lot of voices and shot themselves with a nail gun, and the voices actually stopped, and they went on to be, neurologically intact without issues. So we're mostly going to talk about pseudotumor today, but we do see, probably some different things in Miami that people are not used to seeing, different types of pathology. And in part, that's because we're at such a massive center. So these are some of the centers that I work at. Jackson Memorial Hospital is actually the single largest hospital in the country if you count one building. And then across the street, we have University of Miami Hospital. Next to that is the Veterans Hospital. And then it just keeps going on and on. We've got the two children's hospitals. And then, what's really relevant probably to the IIH community is Bascom Palmer is the next building over, which is the University of Miami ophthalmology department. And this is one massive building. This is routinely ranked the #1 eye, or ophthalmology department in the United States. And I think it's been that way for the last 20 to 22 years. So, on a daily basis, I might be treating things like this, giant aneurysms, things like that, fistulas and other vascular malformations. But, today we're really going to focus on intracranial hypertension and pseudotumor. So I think one of the most important things about pseudotumor is that it is a diagnosis of exclusion. So patients need to have elevated intracranial pressures of an unknown etiology. Common symptoms, as I'm sure people on this website, on this forum know, are headaches. Patients can have tinnitus, diplopia, ophthalmoplegia, meaning problems moving their eyes, which results in double vision, and over time, visual loss. Signs on examination, patients get arcuate visual field defects. When you dilate their eyes and look in the back of their eyes, you see papilledema. Papilledema is a indirect sign of elevated pressure in the brain, as is abducent nerve palsies, which is a cranial nerve 6 palsy where people have problems looking off to the side. And if your pressures are that high, you will start getting severe papilledema with vision loss. And then if they're really off the charts, we see patients where they have bilateral 6 nerve palsies and they can't really look off to the side. About 10 to even 25% of patients that are untreated will develop some aspect of visual loss due to chronic papilledema if they have really severely elevated intracranial hypertension. One of the things that I think is so important, because we have many cases of this every year, is that pseudotumor is a diagnosis of exclusion. It means you have to have an organized workup where you take everything else off the table, because we often have patients that are referred for pseudotumor and they have secondary intracranial hypertension due to some other problem. So these patients really need a careful assessment to make sure that you're not missing something. So, this is a patient with a giant aneurysm that was initially referred for pseudotumor. And this is a pretty obvious one. If you get an MRI, you're going to see something like this. Another patient that presented with progressive visual changes and headaches, on examination, they had grade 3 papilledema. On further discussion with the daughter, she noted that the mother has had progressive psychiatric changes. And she had been, all of a sudden in the last couple of months, had been arrested multiple times, was constantly fighting with the daughter. And she was referred by an ophthalmologist before she had any imaging. So, this was her MRI. And obviously, this is not pseudotumor, this is real tumor. So this was a giant benign brain tumor that I removed, and all her symptoms went away. Actually, she's super close friends with her daughter now, and she doesn't have any problems with the law anymore or any of those psychiatric changes. So all those things went away. And part of the reason I bring this up is because I see patients all the time with presumed pseudotumor, but they don't have an MRI with contrast. So this tumor you're going to find on a plain MRI or a plain CT scan. But we see plenty of cases where you really can't see the lesions or the pathology, even with an MRI with contrast. And we see so many different things that can look like pseudotumor that are not. Something like this. This is a newborn that had respiratory, cardiac alterations. They looked in the back of the eyes. They see the baby has papilledema. And then when you get an MRI, they have this massive, this is actually not a vena gala malformation. This is one of the most rare vascular malformations. This is a dural sinus malformation. So other cases like this, though, I think it's super important that you have clear imaging and that you have reviewed by someone that's a real expert. A patient like this presents with progressive headache, blurry vision, exercise intolerance. This is a young person. On exam, they've got grade 4 papilledema. And then they get an MRI without contrast. And what you see here is every blood vessel in the brain is abnormal. So this is not pseudotumor. This is secondary intracranial hypertension from some sort of blood vessel problem. And you can see here, they have a secondary Chiari malformation at the skull base. In other words, the pressure is so high in the brain because of this vascular problem that the brain is actually getting pushed down through the skull base. And this, these are the thousands and thousands of vessels that are involved. And the key here is just figuring out where the abnormal fistula is. If you block that fistula, that Chiari will go away, all their symptoms will resolve, and this person will go back to being completely normal. So one last case, so just so that I'm not harping on this, but this was a doctor with 10 years of headaches, presented with progressive blurry vision, referred for pseudotumor, on exam has grade 4 papilledema. This person had multiple MRIs, which were read as normal. And I think this is the key. This is a high quality, thin cut MRI that's read at, and he had more than one due to progressive problems, and is not necessarily the usual demographic for pseudotumor. And what you see here is there's a lot of busyness in the bone back here. And this was, unfortunately something that was missed by a multiple neuroradiologists. And you can see back in the bone here, this is really busy. This patient also has a fistula, a torcular dural arteriovenous fistula that's fed by literally every blood vessel in the brain. And it's amazing, that something like someone that has thousands and thousands of abnormal vessels, if they're hidden in the lining of the brain, sometimes that can be missed. So if you go on and treat these patients, with just a shunt, their problems continue to get worse. So all these patients need a really careful, workup that is a diagnosis of exclusion. And then you really need to carefully go through the imaging and make sure you're not missing things. So pseudotumor, once you have a diagnosis of exclusion and you've had a lumbar puncture, or you've had your pressures assessed, and there's no other etiology, there are a number of treatment options. The medical therapy, I usually defer to one of my neurologists or an ophthalmologist. And most patients don't come to see me until they've already been through those lines. Whenever I think about, a surgery or a procedure, my general feeling is that if you can avoid a surgery, that's the best option. So if you can get away with something else that's less invasive or has less risks, I usually think that that's the best option. And I really go through these things with patients as well. So one of them is medical therapy. And unfortunately, we don't have a lot of options for pseudotumor other than medications for headache. And we have some medications like Diamox to try and reduce the pressure. So Diamox is a diuretic that helps you get rid of fluids in the urine. And it's one of the only medications that we've had that's been thoroughly studied for patients with pseudotumor. And that's, I think, is fairly challenging. This is the study from JAMA in 2014, where patients were assigned to Diamox, and there was some benefit. Patients had a decrease in intracranial pressure and improved vision. But the frustrating thing is it's really not that impressive. We start patients out on often a low dose of Diamox, and then the Diamox is increased. But, I often see patients on Diamox, 3,000 milligrams a day, which is not possible for a long-term treatment plan. And a lot of the patients undergo other more aggressive treatments because they're having too many issues with the side effects from Diamox, or there are a number of other medications as well. And that's really where we get into some of these other potential treatment options. One of them is optic nerve fenestration, which is a means to reduce pressure in the eye. And that's usually done by one of my oculoplastic or ophthalmology colleagues. And that does improve papilledema and swelling of the eye. The one disadvantage is it doesn't improve the aspects of the brain. In other words, it's a completely secondary treatment phenomenon where you're just trying to improve visual outcomes. And sometimes patients end up needing multiple treatment options. And so, a common case is someone that's had an optic nerve fenestration. Their pressures are super high. they're still having either visual problems or intracranial problems, and they get sent over to me on sort of like a Friday afternoon. Other treatment options, which I think are the traditional ones, are cerebral shunts. So a shunt that goes from the brain down under the skin to the abdomen. So that's a ventriculoperitoneal shunt. Basically, the brain makes about a half a cup of fluid every day, coats the lining and the inside of the brain, and then it gets absorbed. So a ventricular peritoneal shunt is an indirect way to remove fluid from the brain. Basically, the tubing is hooked up to a valve, and when the pressure is too high, it drains some of that fluid. So it's an indirect way of lowering the pressure in the brain. And a lumboperitoneal shunt works in a similar way as a ventricular peritoneal shunt, or as sort of like a more permanent analogy to a lumbar puncture, which pretty much all these patients should get as part of their workup to assess their pressures. But a lumboperitoneal shunt connects the spinal fluid space with the abdomen with a valve, and again, that indirectly lowers the pressure by draining extra fluid off the spinal system, and so that also lowers pressure in the brain. And we'll come back to the pluses and minuses of these treatment options. A newer treatment option, which we really started looking at in about 2011, 2012, is the venous sinus system, which I think is, what we're really focused on discussing today. And the idea is that patients with high pressure in the brain, especially when it's off the charts, will have narrowing in the veins in the brain. And we really don't know, is it the chicken or the egg? Which one comes first? Meaning, is it narrowing in the veins that causes intracranial hypertension? And that might be the case in some patients. Or is it high pressure in the brains that causes narrowing in the veins, which then perpetuates the process further and leads to increased pressure because the blood is not draining well from the brain? And that is certainly, I think, the case for some patients as well. One of the challenges of evaluating these patients is usually these patients will get an MRI with contrast, an MRA, and an MRV. And one of the challenges is most people, this was a paper we wrote maybe 2016, I think, or 2015 or 14, where we looked at the prevalence of dural venous sinus stenosis in a general population, meaning in patients that don't have pseudotumor. So most patients have a dominant transverse sinus, and a tremendous number of patients have some degree of narrowing or one side that is narrow. And then the question is, well, then how do we know for pseudotumor patients that that's really relevant in terms of how do we know that the narrowing in the veins is resulting in a physiological problem? And that's really where we get to venous sinus stenting and assessment of the pressures in the brain for as part of the workup for pseudotumor. And the way that we do that is we usually go through one of the veins, either in the leg, or more recently we've had in the last couple of years, we've generally been doing it in the arm. So we just put an IV in your wrist. We go into the vein in the wrist all the way up into the brain, and then we can measure the pressures in the superior sagittal sinus all the way down across the narrowing. And if you look at this image here, and I'll have some more concrete examples coming up, but if the pressure is 60 in the superior sagittal sinus, and then once you cross this narrowing down here, if the pressure drops to 5, you know that narrowing is probably contributing to the problem. The intracranial pressure in humans should be less than 15 to 20. So, when you see a severe narrowing in the veins with pressure in the 50s or 60s, you know that that's really going to cause a real problem. So it took quite a while before venous stenting really became a viable treatment option for these patients. And we'll go over a prospective study that we did as part of validating this. I think we started in 2011 or 2012, but we've come a long way since then. And this is sort of what the literature shows. So we published this in 2015, but now there have been many, many more updates on this, which basically are review papers that look at the outcomes for venous sinus stenting versus shunts, ventricular peritoneal shunts, lumboperitoneal shunts, and optic nerve fenestration. And that's really where we still need a lot more research, even though there are many publications about this, to really define, what's the best treatment option based on specific patient and disease characteristics. And that's pretty much, why whenever I meet one of these patients in clinic, it's usually a 1-hour discussion. So in this review, we looked at, or this was actually a review before ours by Dr. K, looking at visual outcomes and headache following interventions for intracranial hypertension. So looking at stents. So they compared headaches and visual outcomes across multiple modalities of treatments. At that time, there were 457 manuscripts selected with 30 studies with extractable data. All the data, generally speaking, at this time was class 3, which is not great. Those mainly mean small patient series that are retrospective. But at that time, there were 332 patients treated with optic nerve fenestration, 287 patients with lumboperitoneal shunts, 61 patients with ventricular peritoneal shunts, and 88 patients in the literature with venous sinus stenting. And so what they found was that visual acuity improvement was the highest in the stenting group. So you can see here about 85% versus 67% for optic nerve fenestration versus 56% or 57% for lumboperitoneal shunt and about 50% for ventricular peritoneal shunt. So that's, I would say we've got a long, this was many, many years ago, but still we have a long ways to go in improving this. Headache improvement is really tough because headaches are very subjective. But at least in this literature review, they found the greatest headache improvement occurred with stenting, next with lumboperitoneal shunt, third to last with ventricular peritoneal shunt, and then lastly with optic nerve sheath fenestration, which I'm surprised that relieved headaches at all. One of the major issues that they found was shunt revision. So shunts are made out of plastic. They're made by humans, so they can break and they can become infected. And that's generally speaking, a giant disaster. And what they found was lumboperitoneal shunts probably have the highest revision rate, 46%. And ventricular peritoneal shunts, it's less, but it's still significant, 36% revision rate for ventricular peritoneal shunts. And the key there is, what is the duration of follow-up? If you follow babies that get shunts as newborns, they have an almost 80% revision rate of shunts if you follow them for 20 years. And we're still collecting long-term data on pseudotumor patients, but generally speaking, if you follow the patients for 10 or 20 years, the revision rates are probably even higher than that. This was another study that was done by this group led by Dr. Ahmed, looking at cost comparison, which I think is less interesting, but they compared stents and shunts. And there's not really much difference in terms of the overall cost for the shunt or the stent, but there is a huge cost for revisions. And that's where there's a major, alteration in healthcare expenditure. If, for every one of these revisions, you're talking about many, many thousands and thousands and thousands of dollars, which is, tremendous for the healthcare community, but also, if you're an unlucky patient that doesn't have health insurance, it can really be devastating. And these things are really significant. So these are important things to think about. This is one of the studies I wanted to talk about, which we actually submitted this protocol in 2010. And this was the first prospective pilot study of intraparenchymal and intravenous cerebral pressure assessment during venous stenting for intracranial hypertension. And at the time, Steve Newman was he's a world famous neuro-ophthalmologist. We did this at University of Virginia, and he really directed this study because he wanted to prove that venous sinus stenting actually lowers pressure in the brain. At this point in 2010, we saw the patients were having good outcomes if they were well selected, but the question was, by what process? And at that point, we really didn't know if stenting in the brain was really lowering pressure in the brain. So this was a prospective study to do real-time intraparenchymal pressure assessments to see, what happened once you placed a stent in terms of cerebral pressure, intravenous pressure, which we normally, at the time we thought was an indirect measure of brain pressure. And that's where I was talking about where we go with a catheter up into the veins, into the brain, and we're measuring the transvenous pressure. But at the time, we did not know the transvenous pressure, how close is it to the cerebrospinal fluid pressure, and how close is that to the actual cerebral pressure. We also wanted to look at technical complications from stenting, because at this point, stenting was very new, and we were working out how do we put these stents up into the brain. So we were trying a lot of new systems to put stents into the brain, and that took some figuring out. We wanted to look at ophthalmological outcomes, neurological outcomes, functional outcomes, which means, how well are people doing in their activities of daily living once they receive stenting? And then lastly, radiographic outcomes. And this was really the first prospective study that started looking at these things. So patients diagnosed with intracranial hypertension were evaluated by neuro-ophthalmology clinic. This was acuity, visual fields, fundoscopic examination, and optical coherence tomography. And I think this is really the key for having good outcomes, is well-selected and well-screened patients. A lot of times we see patients where they go right from their primary care doctor, like maybe straight to a neurointerventionalist that's unfortunately paid to do these procedures without much screening. And unfortunately, those are a lot of the patients I see as, 5th, 6th, 7th, 10th opinions after they've already had so many treatments. And they never really had an excellent workup, by good neurologists and a good ophthalmologist to begin with. And that's where things get missed. And I think in the United States, especially as compared to when I worked in New Zealand, we are unfortunately in a cash system. And so there are unfortunately many practitioners that get paid to do a procedure. And that is a very dark side of our medical field. I like to think I do about 700 cases a year. I don't get paid per surgery. So it makes my life really easy. I treated a homeless person and a prime minister in the same day, and I try and give patients the same recommendation I would, if they were my family member. But I don't know that that's exactly what goes on around the country. And I think that the neuro-ophthalmologists and the neurologists really are the gatekeepers. And that's why I think that this study was so important, because our outcomes with stent were completely assessed by someone that wasn't doing the stenting. So a lot of these papers, we get sort of mixed outcomes because the person that's putting in the stent is seeing the patient in follow-up, and then they are biased by their own treatment. So, if I think I put in a stent, I thought I did a great job, and I'm more likely to say that the patient's doing great. So in this prospective study, Dr. Newman did all the outcomes, and then another neuroradiologist did all of the radiographic outcomes. So all patients were refractory to medical therapy, because again, at that time, we didn't put stents in and we didn't put shunts in until someone was failing maximal medical therapy. And at that point, they would get an MRA, MRV. They had already had a full workup with an MRI with contrast and a lumbar puncture. And those patients with refractory intracranial hypertension then underwent a protocol where they had an intracranial pressure monitor placed, which is actually an invasive procedure. We made a little incision, we make a little hole in the bone, and we actually put a little wire into the brain that measures pressure. And that's a common procedure that we do in trauma patients. So all these patients got intracranial pressure monitoring assessment, and then they underwent an angiogram. And again, the angiogram rules out rare pathologies like fistulas and AVMs and other vascular problems that can cause high pressure. They underwent venography, which means imaging of angiographic imaging of the venous system. And then we went through a transvenous approach and assessed the pressures across any stenosis. And of these patients, those with significant elevations of intracranial pressure, but also with significant pressure changes across the stenosis, were then treated with stenting. And follow-up angiography and venous pressure assessments were then carried out at approximately 3 and 12 months, and then yearly with CT angiography. And baseline and follow-up neuro-ophthalmologic exams were assessed to look at acuity, visual fields, fundoscopic examination, and optical coherence tomography. And on top of that, another independent doctor, like a neurologist, assessed their functional outcomes on discharge and follow-up. And so these were the first 10 patients that were enrolled in the study. I think one interesting thing here is that the body mass index, which has to do with how much muscle and fat your body has, was very variable. I mean, a number of these patients were on the morbid obese side, but you can see here, even this patient, number 8, is actually quite thin. And that's another common misperception that we don't understand about pseudotumor patients, is that some of the patients are morbidly obese, and that goes all the way down to patients that are very thin. One thing that I didn't talk about today, for that's a treatment option that I always talk about with patients in the clinic that do have unfortunate morbid obesity is, these patients sort of get really pushed to, like, you need to lose weight. And I think that's a wonderful thing to try to do, to live a healthy lifestyle and to lose weight. But I don't think that most patients ever choose to be morbidly obese. And if they could lose weight, they would. Or they certainly would try to. And it often, requires behavioral modification, exercise routines, but also sometimes bariatric surgery, because some of these things are genetic. And we do have patients that undergo bariatric surgery and their pseudotumor resolves. And potentially that's the healthiest option for really morbidly obese patients, because, again, they skip the shunt and the stent if possible, but they lose a lot of weight, and that's better probably for their heart and their other, general overall lifestyle. But that being said, not all the patients are morbid obese. Sometimes we have patients with minor obesity and they lose 10 to 20 pounds, and that in itself is enough to bring them down to a normal pressure range. So this was the average transvenous pressure assessments in these patients. You can see that on average, it was about 40. So we well-selected patients in this study with very high pressures. Across the venous stenosis, the average pressure was about 9 to 10. So that's about a 30-point change in the gradient. And I think this is where really assessment of these patients is really important, because I see patients all the time that got a stent and their pressure was never elevated to begin with, and they didn't have a significant gradient. And that is going to lead to problems down the road, because now they've got a stent that maybe they didn't need, or they have a shunt that maybe they didn't need. And so I think it's really careful assessment of these patients is necessary. So in this study, all patients underwent successful stenting without complications. This is the intracranial pressure assessment pre-stent. And you can see here, it was very close to the transvenous pressure. So on average, the actual pressure in the brain tissue was 42. Immediately post-stenting, like the second the stent opened, the average pressure went down to about 17. We kept the intracranial pressure monitor in for another day. On post-stent day 1, the average pressure went down to 8, and the highest pressure recorded was 12. And even in that patient, the pressures went down further in the next day. So this is the overall, there was a 30-point difference in the gradient before, and then post-stenting, pretty much everyone had resolution of their gradient. So what this means here is, after stenting, on average, patients had a pressure of 9 to 8 across the stent. So that's all within the normal range. Patients, this is another key, had a mean follow-up of 16 months. And this is part of the reason it took us so long to do the study. One, patients at that time often didn't want intracranial pressure monitors, because that's another invasive procedure. And then we needed to have long-term follow-up. You can see here the range was 1 year to about 2.5 years. When we looked at this, one of the other keys, and again, this was very early in our experience, we were trying to figure out what's the best stent, how do you get the stent up there? You know, these are cases from a long time ago, and I think we've improved tremendously since then. But at that time, 8 of 10 patients did not have any significant stenosis on follow-up. But 2 patients did have some stenosis adjacent to the stent. When we looked at those patients more carefully, one of the patient's symptoms returned, and she had a maximum pressure of 28. So it was much lower than when she was originally treated, but still not within the normal range. And she had a gradient of 15. So she was the one patient that got repeated stenting with resolution of her gradient and symptoms. And one of the things that we've learned since, you know, this initial study that started in 2010 is you really can't go with short stents, because if you put a short stent in, a lot of these patients, you're not getting to the part of the sinus that's tacked down by the bone, and they will get stenosis adjacent to the stent. So we generally use much longer and much different stents than we did in 2010 or 11 or 12. But generally speaking, when we assessed patients on follow-up, the mean gradient across the stent was 4, and the range was 1 to 7. So the majority of patients were in the normal range. Functional outcomes, you can see here, the vast majority had improvements in their overall functional outcomes. This is a very busy slide, but basically what this shows is that patients had significant improvements in papilledema, visual acuity. Optical coherence tomography is actually an infrared system that measures the thickness of the optic nerve. And that's very important. When you have severe papilledema, the OCT shows the nerve is fat because it's swollen from the papilledema. And so once these patients are successfully treated, the nerve becomes normal in diameter. So it's not fat and it's not thin. One of the other key things that we've learned over time is that some people have chronic elevations in their pressure, and they're sort of beyond papilledema, meaning they start having damage to the optic nerve. And so instead of it looking fat with fluid, it's actually really narrow, and it becomes atrophic. And that's because the nerve is actually dying. And we have actually found that even some patients with optic atrophy can still be successfully treated, and the nerve will go back to a more normal caliber. On top of that, most patients had improvement in their visual field testing as well. So I think this was published, I don't know, many years ago now. But since then, we've gone on to publish, you know, many papers on venous sinus stenting, including, you know, this was another sort of controversial one, which is patients where the pressure is so high that they have bilateral cranial nerve 6 palsies, meaning they have blurry vision and they really can't look off to the side. And those patients usually have pressures in the 60s, 70s, 80s. You know, when you do a lumbar puncture, the cerebrospinal fluid shoots out off the top of the manometer. And so we've had a number of those patients that have been successfully treated. One thing that I do tell patients as well that we still don't have a great understanding for is that some patients with pressures that, you know, maybe are 60, 80 or higher will need more than one treatment. So we may put in a shunt and it brings their pressure from 80 down to 30, but then they need another shunt or a stent or something along those lines to get them from 30 down to 5. So here's a case example. You know, this is a young patient with intracranial hypertension, chronic headaches, progressive visual loss, had a lumbar puncture performed with opening pressure about 40, started on acetazolamide or Diamox, but then their symptoms got worse. So even though the Diamox dose kept getting higher and higher, the symptoms kept getting worse. And repeat pressure assessment, even on Diamox, showed even higher pressures. MRI reveals classic signs, which are optic nerve swelling, empty sella, which is an alteration around the pituitary gland, is something that we see in patients with high pressures. And MRV demonstrated unilateral transverse sinus stenosis with contralateral hypoplasia. So this is the MRV, which shows the left side, everything is flipped left to right, but the left side is basically not filling. You can see this defect. And then over here on the right, there's some degree of narrowing. This is the papilledema assessment by this patient. And this is the optical coherence tomography. And this is the visual fields. So what we're seeing here is severe papilledema, severe swelling on optical coherence tomography. The optic nerve is 4 times thicker than it should be. And then this is decreased visual fields. So this is the venogram. You know, what we see here is it's often difficult to see on the front view, and that's because of the bone. But what we can see here is the left side's not filling that well. And the right side, there's actually severe narrowing here that's hard to see on the front view. But when you look at it on the side, you can see where this arrow is. You can see severe narrowing. And this is why the MRV is often wrong. The MRV is usually a reconstruction of the sinuses, but it's not a direct measure where you're actually taking a video of the sinuses. Sorry, I just had to send a message. Then we put a microcatheter up into the superior sagittal sinus. This is the manometry, and we take these pictures again. And we measured that in this patient. We can see here that the transvenous pressure here is 46. And then below this stenosis, it drops to 9. This patient, if you look at this last image here, you can also see the intracranial pressure monitor. So that's this probe off here to the side, which is actually in the brain. And so while we were doing that, the intracranial pressures range from about 30 to 55. So then with the intracranial pressure monitor in place, we stented the patient. And what we see here is the pressures immediately dropped. They were 14 above the stent and 13 below the stent. And at that point, the ICPs were 52, and they decreased to 14 immediately after stenting. So this was really the first study that showed that stenting directly lowers not just the transvenous pressures, but also the intracranial pressure. And then once we look on day 1 or day 2, most of those patients are down to sort of the 0 to 5 range. And this is what the vein looks like once it's fully opened. This is this patient's follow-up. So what you see down the road is the OCT goes down to the normal range. So it went from 400s down to normal of about 100. You also see the papilledema resolves and the visual acuity gets much better. Another case, you know, children can also unfortunately have pseudotumor. It's certainly much more rare, but this is a 14-year-old presented to ED after a local neurologist found her have severe papilledema with headaches and visual decline. She had a lumbar puncture of 37. You know, again, it's important to rule out all other phenomenon, things like viral or other meningitis, things like that. She was diagnosed with pseudotumor, started on Diamox, but continued to have visioning decline. She had evidence then, by the time she saw us, of optic neuropathy with bilateral arcuate field defects and an apparent pupillary defect, which are all signs of high pressure. You can see here when we measured her pressure, she's got narrowing, which will be more evident on the lateral, but pressures bilaterally were greater than 30. And then immediately post-stenting, they dropped to about 3. And she went on to have improvement in her vision and her pressures and all her other symptoms. Another case, this is a 32-year-old. And again, this one was interesting because when I first was learning about pseudotumor, we thought that the patients were supposed to be morbidly obese, which is really not necessarily the case. This lady actually has very low body mass index, you know, and these patients can appear very thin. She has headaches for 3 weeks, visual loss, 2 lumbar punctures with pressures greater than 50. She started on Diamox, referred for neuro-ophthalmology, neurosurgery. So on inspection, she has bilateral 6 nerve palsies, meaning she can't look to the side and her eyes don't line up. So she has double vision. We placed an intracranial pressure monitor. Again, this was probably in 2011. Her pressures in the brain were in the 60s. So as a temporizing measure for that, we put in a lumbar drain and we performed a venogram. This is her ophthalmologic assessment, which shows, you know, severe findings on her papilledema assessment, her visual problems. These are actually, you can see her eyes are not lining up correctly. And then this is what her venogram looks like. You can see the right side is very atretic, and she has this filling defect or severe narrowing in the left side. Her pressures were greater than 50. One last thing that we've also published on, because I see these patients sometimes as a second opinion, is that when we measure these pressures, it's done with sedation. If you use general anesthesia, that can artificially lower the pressures or do away with the gradient. So I have had patients where, maybe their lumbar puncture was 50, but then when someone performed the manometry, they said it was normal, and that doesn't really fit or make sense. So we published on this as well, but this is this patient's assessment of pressures. You can see here the sinus is not filling well here. This patient goes on to get a stent. You can see here before stent, greater than 50, after stent, less than 5. So that's a huge, huge alteration, 3-month follow-up, imaging follow-up. Now you can see her eyes line up perfectly. Her double vision completely resolves. We have videos online. I'll probably just skip this for the
Dr. Starke, sorry to interrupt you. We have only until the hour, and there are some questions kind of starting to grow. People are super fascinated with your talk and have some questions. So do you want to, I hate to just jump in like this, but do you want to maybe kind of quickly go through the rest, or should we?
Yeah, there's only 1 or 2 slides
left.
left.
Perfect. Okay, go for it. And then then Pierre we'll ask some questions of you.
Perfect. So this is, this was our overall experience of 2018, which was really early on. Before 2015, there weren't a lot of other centers that were doing stenting, but 142 patients evaluated, 72 stents, gradient resolved in all patients to less than 5. 2 patients had groin pseudoaneurysms that resolved with minimal treatment, usually just pressure. Long-term functional radiographic ophthalmologic outcomes were still pending, and we're still collecting outcomes for all these patients. And I say that, that's a big disadvantage. But let's just skip through this. In conclusion, though, venous sinus stenting, it can be done safely, effectively. It can lead to immediate resolution of venous pressure gradient across the stenosis, significant decrease in intracranial pressures, which we don't usually measure anymore. We don't usually put bolts in these patients. Improvement in functional neurological outcomes, improvement in ophthalmologic outcomes. Patients are at risk for stent-adjacent stenosis. I think they need to have long-term follow-up. Part of that also is now we're seeing a much lower incidence of that when we use longer, better stents, and hopefully we'll have some better stents in the future that are specifically made for pseudotumor. I think really one of the main things is we need better prospective studies. The IIH was trying to support an overall very large study to compare optic nerve fenestration, lumboperineal shunt, ventricular perineal shunt, and stents. So, anytime I take time out from my son and family to give a talk, I always like to thank them. You can follow me, at any of these social media areas. It's easy to find, a lot of our references on this online on PubMed, if that's helpful. And maybe I'll wrap it up there because I know we've got about maybe just a handful of minutes left. Questions?
Thank you so much. Dr. Gobin, would you like to come on? I know there are a lot of questions people have been asking in the chat, and also anyone who wants to ask a question, just please speak up. But Dr. Gobin, all the floor is yours, and thank you, Dr. Starke.
Yeah. So we have many questions from patients who are in distress, and they say, last patient is Darius and mom Leslie, saying that they have been going in circles here in Maine. They were told, she was told to lose 50 pounds and that it will be cured. And she's getting occipital nerve block and Botox for migraine, and this is not solving her problem. And we have also, that was just the last patient chatting, but there is a lot of patients complaining about care in this disease, and I think that this is what we are doing at IIH Hub. We are trying to improve the care of this disease, but making patients, but also physicians more aware of treatment of IH and of its treatment. So, I mean, question I cannot personally recommend who to see in Michigan, for example, but I know that as soon as we have solved a legal issue, our website, IIH Hub, is going to have a list of physicians who are interested in IH, and they will be regrouped by state, and every physician who wants to be on this list will be able and will be on our site. Now, there are a few specific questions for Dr. Starke. What are your criteria for the opening pressure on the lumbar puncture? Do you strictly limit yourself to 25? Because I know that at Cornell, we have treated patients who have IH, but you know, the lumbar pressure the opening pressure at the time we did the last lumbar pressure was 22 or 23, and we still treated them, and they improved. So what do you think about opening pressure?
Yeah, that's a tough one. You know, the key to a lot of this is good patient selection. So it's a comprehensive evaluation by neurology and a good neuro-ophthalmologist. The lumbar puncture is important. You know, for me, most of the patients that I treat have very high opening pressure on lumbar puncture. We have seen patients that have been successfully treated with lower pressures, but those are usually the patients that I'm more conservative with. So if your opening pressure is 22, you may be sort of almost into the normal range. And I'd love to see with potentially if weight loss is an option or medications or other things like that, that you can get the benefit that you really need, you know, and then it's really an assessment of the risk versus benefit. You know, it's hard to make a blanket statement for all patients, but generally speaking, the patients that do the best are the ones with high pressure, papilledema, you know, both subjective and objective findings on examination. So we have treated patients with pressures, you know, that are in the lower aspects. I do not treat patients with normal pressure. So if your pressure is 10, I do not treat those patients.
Okay. Another question is, what the best position for a lumbar puncture? So officially, it's a left lateral decubitus. Would you agree with that?
Yeah, I generally speaking, we do it in the left lateral decubitus position. You can also do it prone. You know, that's the way a lot of radiologists do it because it opens up the disc space. I think that that's reasonable as well. You know, generally speaking, if patients are relaxed, either of those are going to give you a fairly accurate pressure assessment.
Okay. And another question, is there a correlation between repeated lumbar puncture and herniated discs?
I'm sure if you looked in the literature, they might say that, you know, that there is a potential for that phenomenon. Generally speaking, you know, you really shouldn't be going so far as the disc space to do a lumbar puncture. Now, some patients, especially in patients that are morbidly obese, a lumbar puncture can be challenging. And I've had to go get, you know, the massive needle. I don't do a lot of lumbar punctures, but every once in a while, I'll do one. And if I'm doing a lumbar puncture, I usually do it with fluoroscopic guidance. So I don't go near the disc space. I guess in theory, if you're repeatedly poking the disc space, could there be an issue with a herniated disc? I guess anything in this world is possible. I'm sure that somebody's reported it. But generally speaking, the size of the needle should be so small that it shouldn't lead to a herniated disc.
Okay. And another question. Have you heard of the external ICP monitor from Brain4Care being used in Brazil? That would be nice on an external ICP monitor.
Yeah, so there's a number of companies that I just talked to another company that has it's almost like an infrared imaging system of the eye that we can use for trauma patients or pseudotumor patients to assess intracranial pressure. A lot of that is being tested and validated now, but I do think that in the future, we'll be able to have better non-invasive ways to assess these patients and follow them, which would be absolutely tremendous. I mean, if you didn't necessarily need to do a lumbar puncture first, that'd be wonderful. So a lot of that's being assessed, and there are multiple companies now that are working on various elements of that for pseudotumor, but also other areas. So you have a trauma, And it's beneficial to know, is the pressure high in the brain? Do they have a bleed or a fracture, other things like that? So great questions.
And another question, is it safe to do repeated lumbar puncture when you have an LP shunt?
That's a tough one. Everything has some risks and benefits. And, if you have an LP shunt, you obviously also want to be careful that you're not hitting the shunt with a lumbar puncture. So again, I really don't do lumbar punctures, but, in the rare situation where I've sort of pushed into doing it, I generally use fluoroscopic guidance so that I stay away from a lumboperitoneal shunt. You also have to be careful if the pressure is low that you're not draining too much, because afterwards, problems with CSF leak, things like that can lead to chronic headaches and things like that.
And another question. So we are not supposed to give personal advice, I mean, medical advice to patients. But here I have we have Darius and Leslie saying, I have had 9 lumbar puncture, and they helped me significantly with head pain. That's really a criteria, that if you don't want to continue with the lumbar puncture, then you need a surgical treatment for IIH. And the fact that the lumbar puncture help you with a head pain is, for me, a good criteria that you need a surgical treatment. What is your opinion, Dr. Starke?
Yeah, I agree. I don't give like personal, patient evaluations over this type of thing without reviewing everything. But generally speaking, if you get a lot of benefit from a lumboperitoneal shunt, from a lumbar puncture, that generally means that you're going to do well with cerebrospinal fluid diversion. Now, indirectly, we've now started finding out that patients, generally speaking, also do well with venous sinus stenting if they have stenosis and a significant gradient. Lumbar puncture
anyone
8 to 9 times sounds like too many to me.
That's too many, and this patient has a stent already, so maybe she needs.
Yeah, maybe
in some centers, patients like this who have a stent, the stent worked, but it's not enough, and they are relieved by lumbar puncture. I know some centers will place a shunt at that point.
Exactly, and that's what I was saying. If your pressures are 90, one procedure may not work for you. And we've had patients that needed, they got a shunt and the shunt took them down to 30, and then they got a stent and then they went down to 5.
Yep.
Or we've had patients with bilateral stents or bilateral shunts.
Another question, and is anyone doing a clinical trial in US for external ICP measurement or monitoring, and how can a patient get involved?
I don't know about the involvement, but there are a number of companies that are doing various studies. The ones that I know about most recently have been in Europe. But I do know that there's one very large company that's going to be opening a US trial shortly.
Do you know which one?
I don't, unfortunately. I just don't remember the name of the company off the top of my head, unfortunately.
Okay. Could it be Brain for Care?
I honestly don't remember.
Okay. Another question. Does University of Miami have the ability to test jugular veins with a Doppler US machine?
We will all, you can, but a lot of times we use other means like a CTV or an MRV, but you could do a Doppler ultrasound as well.
So you could, yes, okay. So you could do an MRV. Okay. That's a good advice to give our patient. Okay.
I think there was one more question, Dr. Goban, about GLP-1 agonists, or do you want to, should we go with that last question?
Do you want to, we don't have a lot of time. We have, but just one question, last question about Ozempic. Do you have any experience with it, Dr. Starke?
Sorry, what did you say?
With Ozempic, GP1A agonist.
I don't really have, and other than, I really think of myself as sort of being on the surgical side. So the things that are outside the stents and shunts, I usually defer to other doctors.
Okay.
Well, I want to thank you very much, Dr. Goban, for moderating and passing on all those questions. Thank you, everybody, for asking questions. If we didn't get to all of them, we will do our best to respond by email. Dr. Starke, thank you so much. We'd like to invite you to our next talk, which is Tuesday, November 21st at 4 o'clock in the afternoon, East Coast time in the US. Our speaker will be Dorothea Altschul, MD, who happens to actually be who's been attending this talk today. So thank you for joining, and we look forward to you presenting next time. She'll be talking about pulsatile tinnitus, which that's the medical term. We all know it's whooshing sounds in the head, not fun, and very distracting and very uncomfortable. So she will be talking about that. She's director of neurointerventional neurosurgery at Neurosurgeons of New Jersey and at the Valley Hospital. So we hope to have you there. If you are already on our mailing list, you will be reminded of it and sent links. And in the meantime, please continue to check out IIH Hub. Please send in questions. Please follow us on social media and follow Dr. Starke. And thank you so much.
Thanks, everybody. Thanks so much for having me.
Thank you, Dr. Starke. Thank you all.